And so the role of medicine, as I understand it, as we practice it, is to kind of turn down the noise that's involved with these symptoms so that people are able to hear the therapy, able to make the changes. And when you're able to dial down these physical responses, then it becomes easier.
And welcome to RecoveryTV Live. We're here with a very special guest, and we're going to talk about medication and mental health.
The question is, I struggle with controlled medicines, and then you're going to give me a controlled medicine, and what are we doing here? How are we navigating this?
We have a really special guest today. Her name is Dr. Jennifer Morris. And let me just tell you a little bit about her just before we bring her on. She received her medical degree from the University of Oklahoma Health Science Center, and she worked in the field for a few years before starting her practice called Edmond Psychiatric Associates. It's a group practice where she and her team provide state-of-the-art treatment in psychiatric outpatient care. She's delivered many lectures on medication management, treating depression, eating disorders, and so many other things. We're super happy to have her here with us. So, Dr. Morris, thanks. Yeah, super excited to have you.
Thank you very much.
Yeah. So, what is that? Transcranial Magnetic Stimulation. What is that?
Sure. Repetitive transcranial magnetic stimulation is a newer therapy modality that has been developed to help folks with refractory depression that has failed to respond to antidepressants, or folks who are having side effects to medicines or have other reasons that they would be unable to take psychiatry medicines. And essentially, it's magnetic pulse therapy to a part of the brain right here called the prefrontal cortex. We know that in depression, there's a decrease in blood flow to this part of the brain. And if you can drive blood flow to that part of the brain, then it can give an improvement for depression. So it's a 26 to 35 treatment series. There is some time invested delivering this treatment to deliver magnetic pulse externally to this part of the brain to drive that blood flow and improve depression. And we tend to see in responders a considerable improvement in depression in about the 2 to 3 week mark. Most of the folks that we treat are folks, again, that have been through a number of antidepressants, and then some of my patients that are planning pregnancies and want to see if they're able to do a pregnancy medicine-free. Will do RTMS prior to pregnancy to try to have a medicine-free pregnancy. There are medicines that are considered safe in pregnancy, and I never want to discourage a pregnant woman from pursuing treatment for depression, but that this is another option that's available. There is, of course, a risk-benefit that's there for treating women that are planning on being pregnant or who are pregnant. And when you're looking at these patients, you're not looking at one patient, you're looking at two patients, and you're looking at a family. And so we want to always consider treatments that are going to be safe for the mom, but also safe for this little life that's developing. Depression itself is a danger to a healthy pregnancy, and for reasons all the way from the inflammation that's caused from depression to a mom that may not be able to take as good care of herself, either with prenatal or nutrition or making decisions, that sort of thing. And so we look at it as a risk benefit. Do the risks of these medicines outweigh the benefit that may be there to the depression, both for the mom as well as for the baby? So when we're treating those ladies, we treat in conjunction with the OB-GYN and then sometimes in conjunction with the high-risk perinatal specialist to assess this risk-benefit. But many, many times the benefit absolutely lies in treating depression, again, both for the mom as well as for the baby.
I'm glad to hear you say that. I know that for me, when I'm working with women that are planning on becoming pregnant or are pregnant and they have a history of taking that medicine and they're very apprehensive about it, I always encourage them to talk beyond their obstetrician gynecologist and try and find a psychiatrist to talk to about it. And a lot of times that's in response to the anxiety that my clients are having about medicine during pregnancy. But could you speak to a little bit about how that's helpful for them to see a psychiatrist at
Absolutely.
that time? Okay.
And not only to see a psychiatrist, some psychiatrists are more comfortable working with this, with a pregnant population than others. So ensuring that they're seeing a psychiatrist who's comfortable working with women that are pregnant. I believe that one of the reasons it's important to see a psychiatrist is that we're familiar with working with this specific concern, and then we also have experience in coordinating with the OB-GYNs and with the high risk, so the perinatal specialists, to get that up-to-date information. In fact, there's a whole specialty in psychiatry that's committed to treating pregnant women, and you can go and do a fellowship and so forth. And there are some good online resources, and I can get those for you guys and have them available for you to post later. There's some good online resources to be able to navigate that, and we as psychiatrists are familiar with navigating those resources as well and bringing that data. I would share that the pendulum swings from there's nothing safe in pregnancy to everything is safe in pregnancy, and probably the reality lies somewhere in the middle. Some of these things are safe, some of them are not safe, so we always want to be careful with what we do, but we also want to make sure that we're not under-treating and that we're treating the patient for the concerns that they have that need to be addressed.
Can you elaborate a little bit more on the Suboxone treatment? Tell people what it is first and then how it works.
Absolutely. So Suboxone, or Subutex, the primary component of that is a medicine called buprenorphine. It is an opiate medicine with what's called a long half-life or a long duration of action. And what that means is that when you take the medicine, it stays in the body with a very smooth effect to try to reduce kind of the up, down that can come with classic opiate medicines, and therefore reduce cravings and withdrawal. It's a medicine that's not without controversy, because when we're looking at this medicine, we're looking at working with folks that have had some struggles with controlled medicines. And so then the question is, I struggle with controlled medicines, and then you're going to give me a controlled medicine, and what are we doing here? How are we navigating this? So the thought is that the foundation for recovery is always therapy. It is always therapy. Even with Suboxone and Subutex and the best medicine that's out there, therapy must be in place, or enduring recovery will be very, very challenging. But a lot of times when folks are recently in recovery, they still feel really raw and edgy. They're having cravings, they're having withdrawal, they're very anxious, they don't feel good. And then they're faced with all of the changes that they have to make in their lives. I've got to change my friendship groups. I've got to change how I do things. I may even be changing like my route to work or to home, so I'm not driving by that house of the person that used to give me pills. It's hard to make those changes. And it's hard to hear the therapy and be able to navigate the recommendations that are being made when you feel so physically horrible. And so the role of medicine, as I understand it, as we practice it, is to kind of turn down the noise that's involved with these symptoms so that people are able to hear the therapy, able to make the changes. And when you're able to dial down these physical responses, then it becomes easier to hear what my therapist has to say, to be able to take a different route to work, to be able to listen to my child fussing at me without having to find something to kind of calm that down. So we look at medicine to reduce those symptoms. In the context of that, then, the patient really must be engaged in therapy, because otherwise we are just replacing one opiate with another. And granting it's an opiate that's a little smoother, but we've just done medicine replacement. We haven't made those changes. If somebody is not engaged in therapy, then chances are they're going to be seeing somebody like me for the long haul, because they haven't been able to make those life changes. So it's a great example of medicine and therapy working together to come with the best result, as opposed to, hey, this is better than that was. Let's come up with a perfect result, and people are able to get their lives back.
Well, it's interesting, you kind of brought up how we come together, which is psychotherapy and medicine coexisting.
Absolutely.
And how do you integrate that into your work?
Sure. So as part of our specifically to Suboxone, and then broadly, of course, to other medicines, but specific to Suboxone and to our substance abuse practice, we have it as a requirement of our program. And so patient comes in and they are going to engage in Suboxone replacement therapy for their opiate struggle. Then the very next thing we ask is, what is the therapist that you're involved with, and here's our release so that I can communicate, so that we can make sure we're providing coordinated care. Mm-hmm. And then if you don't have a therapist, let me help you to get one so that you are able to make the most of your recovery. Mm-hmm. We call it potentiation, 1 + 1 = 5 kind of result. It's not even a 1 + 1 = 2, like 1 + 1 = something so much greater. They build and potentiate one another to get a best response.
Right. What are some of the general fears that people typically have when they first come in, first time medication users, basically?
Some of the biggest concerns that we get, or that I hear rather, one, is this medicine going to change who I am? Mm-hmm. Is this medicine literally going to take me over and then I don't even recognize myself anymore? I'm just kind of like a different person, so to speak. And I would encourage that sometimes there are side effects to medicines, and if a medicine is doing something like squashing you out, causing you to not feel like yourself, that's a side effect, not a goal. And so then I would always encourage somebody to express that to me, because that is absolutely not our endpoint. The goal of medicine, of good medicine, is to help to dial down symptoms so that you're able to be yourself, because yourself is not this person that's so significantly impacted by depression or by anxiety that you're not able to function, you're not able to make decisions, you're not able to think, you're not able to relate. So if we're able to take those symptoms and reduce them, then you get to be more of yourself rather than another self or somebody other than who you are.
Right.
But I think that these side effects are out there, such as feeling flattened or squashed out, or difficulties with concentrating, those sorts of things. And I encourage folks, if those are side effects you're experiencing, by all means let me know, because in no way is that the end point. That's something that we need to avoid and need to move away from.
We really encourage people to seek out a psychiatrist when they're doing that, because there might actually be just some kind of little adjustment that the primary care physician might not completely understand that you understand.
Sure.
And then everything starts working better.
Absolutely. I think primary care, and they have to know everything about everything.
Yeah.
I have
so
no
overwhelming.
idea how these guys do it. When I went to medical school, then you get to have an opportunity to decide, like, do I want to do this? Do I want to do this? Do I want to do this? And I thought, I am not going to do primary care because that is so hard. There's so many things to know.
Yeah.
And so I think primary care does an excellent job many times with mental health. But for when it comes to some of these more challenging complications, then it's like, hey, you know what, let's get the opinion of an expert. Let's see what's going on. Can we do this different? Can we do it better? Can we do it other than? And that's why we're here, is a resource to see, is this the best answer that we have? Is there something that we can do different?
Kind of talking about that, one of the things that I've observed a lot in my clients that are struggling with, even from depression to anxiety, all of that, is some sleep issues. And that's another reason that I tend to lean towards, I'd really encourage you to find a psychiatrist, because sleep, we know, is so important and so foundational to just all of mental health.
Absolutely.
And making sure that you're using medicine that can help you. I guess I get concerned that there's too much medicine, and I get concerned that there's not enough.
Sure.
And so that's one of the reasons I really encourage my clients to reach out for a psychiatrist.
And so when people go to see psychiatrist or to see primary care, we have so many concerns there to address. And with an insurance model, it's such a limited amount of time to be able to address all of these concerns. With mental health, I'm able to focus in on these specific concerns. So I don't have to worry about I'm treating your blood pressure, and I'm treating your diabetes, and I'm treating your depression and your insomnia. And so I have the opportunity to really focus on these specific concerns. How is your depression? How is your anxiety? How is your sleep? And then because my focus has the opportunity to be narrowed, then I'm able to deliver a different kind of response to that and incorporate the insomnia assessment and the depression and the anxiety and bring those into a full picture.
We're in the Bible Belt, you know, and
Right.
so, you know, we're people of faith. We know a lot of our clients are people of faith.
Absolutely.
And something that has been traditionally, I think, kind of a message that you kind of see in religious communities is that, you know, if you're dealing with depression, then your relationship with God needs to improve.
Sure.
Or something that we hear a lot, or that we don't hear it as much anymore, but we kind of, when we do talks and stuff, when we're talking to ministers, we try to make sure we send this message that in doing sex addiction treatment, because that's our main field, that someone comes into your office and says, I'm having a problem with porn, you know, a lot of times people are hearing their ministers say, well, let's work on your relationship with God.
Right.
And what I tell them is like, please don't tell people that they need to get their heart right with God, you know, because they're in your office because their heart is right with God,
Sure.
their heart's in the right spot, or they come to therapy because their heart's in the right spot. They're reaching out because their heart's in the right spot. There's a lot of brain stuff going on that we have to work with, and it can get kind of frustrating. People hear that's really discouraging for them because their faith is important. So what kind of things have you seen in your practice, or that you've had to deal with patients that are going through that aspect of it?
So I've had a number of patients who have come to clinic and understand that there might be a need or a benefit from medicine, but they're concerned on one of two fronts. Either concerned that they personally believe that their faith must be weak, otherwise they wouldn't be in my office, or that other folks are going to accuse them of their faith being weak, otherwise they won't be in my office. And agreeing, you know, the Bible says, it's 1 Peter 5:7, cast your anxieties on him, for he cares for you. And so there is this element that we do need to bring these concerns to our faith and address these things address our concerns through faith and through prayer, absolutely. But that we are a soul, we are a body, we have medical things that happen. And my folks that are of faith, if they have diabetes, if they have asthma, then they're not being accused of being weak in their faith when they're having these medical concerns addressed. So to that same end, and using depression as an example, I would view depression as a medical illness also. I look at depression like I look at the diabetes model. Diabetes is a well-established medical illness. It has a medical component where there's a medical treatment for it. There's also a social component of exercise, and then some decision-making, good nutrition, eating healthy, maintaining healthy weight, those kinds of things, so that a patient has things that they can do to get it better, and then ultimately we often rely on a medicine to get things better. And depression is a very similar model where there is a medical component often to depression, and then there's also the things that I can do to get depression better, therapy, maintaining my faith. These elements, they definitely do help depression, and being in a healthy faith relationship helps depression, no doubt, but sometimes it's this physical illness that also needs to be addressed.
Right, exactly. For people that are watching this possibly and thinking about taking that step to better their lives through entertaining the use of medication, what would be a message you'd want to send them, like to be like, if you're going to walk away with anything today, I want you to walk away with this?
Absolutely. If you're contemplating seeing a psychiatrist or contemplating considering medicine, then that means, you know, there's something that's going on that it feels like there's an opportunity to improve. So I don't know if I have a final message so much as kind of like a series of thoughts that if you are going to go see a psychiatrist, then recognize first that you don't have to make a decision on the spot that I'm going to see a psychiatrist and I'm going to get medicine and I'm going to take this medicine the rest of my life. You still have opportunities to make decisions all the way through this. Go visit with a psychiatrist and see what do they have to say, and then evaluate, is what they have to share the best, you know, plan or idea for my life. If you're not sure, go get another opinion, bounce it off people that you trust, bounce it off the therapist that you trust or people that you care about that are in your life, and evaluate, is this a direction that I want to go? But I think a lot of times people are afraid to come see somebody like me because it's like, okay, I'm going to go and I'm going to get stuck on medicine and this is what the rest of my life is going to look like. This is an opportunity for change, not a mandate that the rest of your life is going to be in a particular direction.
Right. Well, we really appreciate you
Thank
being
you.
here again. It's so wonderful talking to you, and we hope this. We know our paths will cross again and stuff. But thank you so much for being here. We just want to thank everybody for watching this today. I hope that you have someone like Dr. Morris in your community, because as you can see, psychiatrists aren't these big, bad, scary people that are going to get you hooked on drugs. And I mean, they really have a heart for what they do. They understand what they do. And I'm sure in your community, there's someone like that. And take that step, go see them, talk to your therapist about it, and let them walk you through it as well. We have, in 1 week, we want to see everybody back here. We have Tyann Truong coming in to talk about postpartum depression. We're so excited to have her.
There has been a significant movement both in the psychiatry community, the mental health community, as well as in the obstetrician community to screen for, address, and treat postpartum depression. And it's exciting to see this. This is a population that has been inadequately, whose needs have been inadequately met in the past, and I think that we're coming to a time where we realize and are able to meet their needs effectively.
Right.
MN Psychiatric Associates was designed and conceived to meet the psychiatric needs of our community kind of in a private practice setting. We're over at 164th and Penn. By and large, our focus has been major depression, generalized anxiety, bipolar disorder. We treat attention deficit. And then I have a special passion for working with substance abuse. And so we have a conservative Suboxone / Subotex practice that we're engaged in as well.